Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight. Policy Spotlight is a series of virtual discussions that we launched in 2021 at Health Affairs. We feature in-depth conversations with influential health policy experts. I've had guests including CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Bob Califf, Nora Volkov, the director of NIDA, the National Institute on Drug Abuse at the NIH, and many more. If you missed any of these programs, they're all recorded, as this one will be, and you can view it on our website. Today, I have the pleasure of speaking with Dr. Doug Jacobs, who is the Chief Transformation Officer at the Center for Medicare within CMS, the Centers for Medicare and Medicaid Services. We just published a forefront piece by Dr. Jacobs and colleagues providing an update on Medicare's value-based care strategy, and that will be the focus of much of our conversation today, although we may cover other topics as well. We're looking forward to being able to talk about the direction of Medicare and where it is going. Before I introduce Doug, I just want to remind those in the audience that if you're watching us live, you do have the opportunity to submit questions through the tab at the bottom of the screen. I'll do my best to bring them into the conversation. It helps if you get them in on the earlier side, and if they're brief and likely to be of general interest, I'll do my best to include those in the conversation. At this point, though, I'm happy to formally introduce my guest, Dr. Doug Jacobs, as I noted, Chief Transformation Officer in the Center for Medicare, formerly the Chief Medical Officer and Chief Innovation Officer in the Pennsylvania Department of Human Services, worked a lot with the Medicaid program and worked on programs around value and equity, which should be familiar as we have the discussion today. Dr. Jacobs earned his MD at the University of California, San Francisco School of Medicine, has an MPH from Harvard University, received his bachelor's degree at Brown. Dr. Jacobs, it's great to have you here. And as always, I'll sort of start with the broad question. I like to let my guests lead the way in the conversation. I've alluded to the forefront piece that you published, but if you could just say a little bit about what you view as your top priorities in the position, and then we'll dig a little deeper into them.
Sure. Yeah, it's great to be here with you all, and really excited for the conversation. So, in my role at CMS, I'm in the Center for Medicare, and I help to lead on issues related to value-based care, health equity, primary care, and behavioral health. I co-lead the National Quality Strategy and also issues related to transparency. And in the Center for Medicare, we cover both traditional Medicare and Medicare Advantage, and so a lot of these issues span across both traditional Medicare and Medicare Advantage as well.
So I want to just sort of dive right into the outline provided by your forefront piece, because I think it captures, you wrote it and it's your update on what you're doing. And I want to bring the quality dimension in particularly. It's an area that I'm always interested in digging deeper into. So in your forefront piece, you described sort of three dimensions: alignment, which is where I'll start, and then growth and equity. So I'm fascinated by the topic of alignment because on the one hand, Medicare is huge, and we want alignment within initiatives inside Medicare. We also, clinicians, and you are one, speak all the time about the importance of alignment across payers. And yet, what I always am struck by, having worked in state government, as have you, is that you can align, Medicare can sort of see itself as the center and everyone align around it. But sometimes you're out there saying, wait a minute, we've got a good idea. Can you align with us instead of us aligning with you? So I know it's a really broad topic, but I'm just interested in sort of how you think about what is successful alignment in the multi-dimensional health system we have.
Yeah, thanks so much for the question. It's a great question. So I'm a primary care provider, and I continue to see patients on a weekly basis. And when I see patients, when they come into my office, I don't look at necessarily the payer that is paying for their care. And that's true with a lot of clinicians as well. And so it becomes really hard if a lot of the different payers, Medicare included, also Medicaid, commercial insurance, employer-sponsored insurance, if a lot of these payers aren't paying for similar quality measures or have similar value-based care arrangements, it's really hard to know exactly like how to focus one's efforts in terms of population health and achieve success. And so when we think about that idea of multi-payer alignment, it's really that at its core and trying to make it so that there's a streamlined way to improve health outcomes for folks. And um, some of the areas that we think about alignment in particular, it includes quality measures, and we can definitely go more into that. It also includes the way that we deliver data to the providers. So also payers oftentimes have these individual patient portals or payer portals where individual clinicians can log in and see their specific patients. Well, if all the different payers have their own portal, it becomes really challenging to like log into all these different ones and figuring out if when you look at across the population of primary care patients that one is treating, like how to actually improve the quality outcomes for that entire population. So we've really been thinking about efforts to align across payers. And that is, you're right, Medicare is huge. One in $5 spent in the US healthcare system is Medicare. And oftentimes what Medicare does, many other payers tend to follow, whether that's rates in terms of percentage of Medicare, what Medicare is paying for. And so when we think about Medicare also in the quality measure space, we've come out with what's called the Universal Foundation. And this is a universal set of quality measures, not just in Medicare, but also in Medicaid and the commercial insurance. And we are moving to that universal foundation across really as many quality and value programs as we can. And so we think that, going back to that situation where I'm the provider or there are other providers who are seeing patients from multiple payers, at least being able to focus those efforts on that singular set of quality measures. And on the data piece too, we recently came out with a rule that allows providers to basically request data in a streamlined way across payers too. And we think that that will lead to a lot of burden reduction, better health outcomes for folks, better understanding with the different types of gaps that exist for the entire population being treated by different providers. So there's other aspects of alignment too we could go into, but I think that allows I think both state Medicaid programs, Medicare, commercial insurers to rally around a set of quality measures, data, and other aspects as well.
Oh, well, let's go a little more into quality measures. So I was involved in the creation of the first set for CHIP for children, and it was agonizing to align, and you've got this huge proliferation of measures, and then there's this constant tension. What you want a relatively modest number of measures so that they're meaningful and people can act on them. But I always heard from clinicians about, well, that doesn't really capture, my experience of quality and the way I think about quality. So how viable is it to center around this core, and how realistic is it to think that others won't say, sure, I'll start there, but let me tinker with it?
Yeah, I think you described it well. It's a tension. On the one hand, we have more quality measures than we ever have in terms of being able to measure intricate aspects of our healthcare system that we were never able to before. And on the other hand, we have this burden issue when these measures aren't aligned. And so we really tried to center the Universal Foundation in terms of like the most widely applicable measures across the different payment settings. And we think that we've done that for both adults and pediatric settings of care. And we also have acknowledged that Universal Foundation measure set is just that, it's the foundation. And so there might be other like settings of care, like in hospitals or skilled nursing facilities, where there are more specific hospital type measures or skilled nursing facility type measures. But insofar as we have that foundation, whenever those measures are applicable, they should be used for first and foremost. And so this avoids things, for example, like, one program saying you need to get hemoglobin A1C, a marker of diabetes, below 8%. And then the other program saying, oh, actually for that quality measure, you need it below 9%. And those little small differences can be really challenging from a provider's perspective. And so we have now a work group internally within CMS that is continuously like taking each of the quality programs and looking to see where there are opportunities to align and how can we best get there.
I'm also interested in the primary care specialty alignment, and you make reference to it in your piece. You mentioned your practice. Um, the nuance of quality, of payment, episode definition, whatever dimension you want to take, when you move into some of these bundles and payment methods that are designed more around specialty care than primary care, seems to open up yet a whole other dimension where alignment becomes complex. Again, I know it's a fairly vague question, but can you say a little bit about moves to align or in the specialty arena, in addition to around primary care, where I feel like there's been a lot more work on sort of core measures?
Yeah, that's a great question. So a lot of the primary care measures are really this universal foundation measure set. And we have, so just for additional background here, we have the MIPS program, the Merit-Based Incentive Payment System. And this is the most widely participated quality program for clinicians. And it gives clinicians an upwards or downwards adjustment based on their quality. This program, historically, clinicians are allowed to select from hundreds of measures to choose from. And what ends up happening a lot of times is that the incentive is for clinicians to select the measures that they already do the best on, rather than really transforming the way that they're doing care. And so part of the way that CMS has started to address this over time is through creating what's called MIPS value pathways, or MVPs. And what that is it's a aligned, discrete measure set for individual specialty types or individual types of clinicians who are treating a certain kind of patient with specific clinical conditions. And so for primary care, there's a value in primary care MIPS value pathway, and that incorporates now all of the universal foundation measures. And primary care practitioners also, we expect that over time we're trying to get a lot of them into accountable care relationships with their patients. And our goal is 100% by 2030. And so in the Medicare Shared Savings Program, we've also had requests for information about moving to the Universal Foundation measure set as well. So creating this aligned pathway for primary care providers to basically move towards more advanced payment models. And then on the specialty side, those MIPS value pathways, those MVPs, there are also those MVPs for specialists as well. And the agency has said that by 2027, I believe, we're trying to sunset traditional MIPS and get to this future where MVPs are really the predominant way of reporting. And so and with those MVPs too, there might be certain situations where that universal foundation of measures like also applies, whether it's blood pressure control or diabetes control. It's relevant in a lot of different specialty types. And so we're increasingly moving to that type of model. And in the blog, we also talk about strengthening MVP reporting as well. One other piece here, just because you were mentioning primary care, I want to mention just today, actually, we announced a new model. And it's the PC Flex model, the primary care flex model, which is a new model built into the Medicare Shared Savings Program that gives enhanced payments for primary care providers in the Medicare Shared Savings Program context. And so we talked about alignment earlier. Another way that we're aligning internally is the Innovation Center, the Center for Medicare and Medicaid Innovation, CMMI, is testing this model within the shared savings program. And so whatever parts of it are successful, we can scale it to the Medicare shared savings program writ large. And so this new model we think is really exciting and gives additional opportunities for primary care providers to participate in the shared savings program. So when I mentioned earlier that pathway that we're establishing through quality measures, we're thinking about new ways of building on top of the shared savings program as well.
I want to come back to alignment, but I did just get a question from the audience about patient-reported outcomes as part of the measurement enterprise. The questioner was skeptical about the alignment between the measures you use and what patients care about. I'm rather than sort of getting into that, I'm just going to ask more broadly whether what role you see for patient-reported outcomes in these core measure sets, if you will.
Yeah, that's a great question. The agency is broadly interested in in increasing the amount of patient-reported outcomes and increasing the different areas in which they're used. And so historically, we've had caps, and that has been in various settings, and it's part of the Universal Foundation as well. We're thinking about patient-reported outcomes more broadly as well, and probably one of the more famous areas that they've been used is, for example, in hip and knee replacements. Just getting information from the patient about what their functional status is after the hip and knee replacement. So insofar as we can, like linking these patient-reported outcomes to the type of care that people are actually providing is something that the agency is broadly interested in.
I'm going to stick with the alignment theme for a while here because, again,
Sure.
as you heard at the outset, I just find it so fascinating. I'm interested in, you mentioned another program, another model. And, we've had conversations for quite some time since CMMI has been around about the metaphor used when it was first created was, we're throwing a bunch of things at the wall to see what sticks. And then people were like, okay, we've thrown a lot at the wall. We've learned a little bit about what sticks, maybe what doesn't. It's not a great metaphor, but it's the one I always heard at meetings. And yet we need to continue to learn. And so my question here is, as you describe yet another sort of model, the degree to which you think we are able, and this maybe also gets to your second area of growth, the degree to which you're able to say, these are the things we really feel like we know they work, and we want to put a lot of our emphasis on them and encourage clinicians to move into them. And the degree to which you still feel like not just refine, but actually introduce new approaches. Where do you think we are on our learning cycle here?
That's a great question. So part of my role within the Center for Medicare is to take lessons learned, things that we already know are working, and figure out ways to scale them into the Medicare program writ large. And I think Liz Fowler likes to use this example of the Medicare program pretend it's like this big oil tanker, large ship, and CMMI acts as the icebreaker ahead of it, trying to chart new territory and making sure that that things work before the big boat comes in. And I think it's been an appropriate metaphor. And so you're right, there are areas that we found out over time through different CMMI models or otherwise that are just working. So some examples of that, the CMMI tested the accountable health communities model, and it tested screening for unmet social needs, connecting with community-based resources. Medicare, for the first time, just finalized a code that just pays for social terms of health risk assessment based effectively on that CMMI model. We also have now this last year finalized new codes for care navigation. So codes that we called community health integration, principal illness navigation, services historically rendered by community health workers and care navigators and peer support workers. A lot of different CMMI models have also tested that in various ways, shapes, and forms. And there's a broad literature now showing how community health workers can reduce disparities. Similarly with peer support workers, care navigation for things like cancer. And so we created and are paying now, starting January 1st of this year, for those types of services. And I think it speaks to a broader approach of where areas we know have been working. How can we take those lessons learned and apply them into the physician fee schedule? And so we pointed to the fact in that blog, like there's been more than 10 years of primary care models tested by the Innovation Center. What can we take from there to think about more broadly? And also that approach that we're talking about, that I'm talking about in the physician fee schedule, has really been the approach that's been more longstanding in the ACO space, because we have the Medicare Shared Savings Program, the largest ACO program in the country. That's a permanent program, serves about 11 million people with Medicare. And then we have had these tests over time that the Innovation Center has tested. And so we are thinking about areas, for example, ACO Reach is the Innovation Center model that's an ACO model and is testing all these new features related to health equity. And so in real time, we're looking at the kind of information they're getting, how is that promoting participation in underserved communities? What do the results look like as a result of these new features? What should we think about building into the Medicare program at large in the Medicare Shared Savings Program itself? So I think that we're operating in a synergistic way and in ways that we haven't historically worked because we have a much more cohesive, I think, aligned strategic goals here.
I'm going to bring in sort of the theme of growth, since you've done so, and it makes me wonder as I listen to you. Of course, we've known for some time that CMS has this vision of moving everyone into an accountable model, but you just described sort of what I would consider helping improve the fee-for-service model. I'm reminded of something my old colleague at the Urban Institute, Bob Berenson, said, which is, we put a lot of energy into these fancy new payment systems. I'm paraphrasing, obviously, but there's a lot we could do just by fixing the fee schedule. And so I'm hearing, I think, sort of a and both kind of comment, but I want to make sure I'm hearing it correctly. That on the one hand, you really do want to move people into fully accountable systems, but at the same time, is it that you don't know how quickly that will happen, and so you want to improve codes and opportunities for coordination within what I would say is not a particularly accountable part of the system? Or is it what is often noted, that the alternative models always tend to build on a fee-for-service chassis anyway, so you kind of want to fix that and it'll ripple through? Sort of what's the thinking about simultaneously trying to move people into a different system while you're fixing a system that you say isn't really what your long-term vision is? I hope that question made some sense.
Yeah, it does. And you're right, and that's how we think about it. They're not mutually exclusive. So improving some of the payments in the physician fee schedule, because all of these ACO models are built on the fee-for-service chassis. I'll just use the example of these new care navigation codes that I talked about. Introducing them and paying for them in the fee schedule is important for a few reasons. I think number one, it gives clinicians the ability to and the muscle memory of like providing those services in a fee-for-service context. And so when they start providing these services, it allows, when we then say to them, okay, well, join an ACO model, like these are all the reasons for doing so, it becomes easier for them to join an ACO model and succeed. The other piece is that the ACO benchmarks, so just for viewers that might not, or listeners that might not be quite as well versed in this area, all of the ACOs have a financial benchmark that they have to meet. And basically what the financial benchmark is, it's looking at all of their assigned beneficiaries and estimating what they're going to cost in any given year. And if the ACOs come under that cost, they can share in savings if they do well with their quality measures. And if the beneficiaries cost more than that benchmark, then they might be responsible for paying some money back to CMS. And so the way that those benchmarks are developed, it's based on fee-for-service claims. And so when we start paying for something in a fee-for-service context, it gets built into the benchmark over time and assumed to be part of the care that ACOs are providing as well. I'll also say that in the Medicare Shared Savings Program, and this gets a little bit wonky, so I'm going deep. But
we have a wonky audience, don't worry.
Perfect, okay. When the way that it works in the Medicare Shared Savings Program as well is they continue to bill individual codes. And so what that does is if they can now bill for something that they couldn't bill for before, it allows ACOs to get more real-time funding to do that service. And so it actually incentivizes ACOs to be performing that service as well. And finally, what I'll say is I think the fee schedule historically, because of the issues with quality that we discussed earlier, in that clinicians can basically choose whatever measures they've already been doing best on. And it doesn't necessarily drive that care transformation. But as we think more about strengthening the reporting of MIPS value pathways, perhaps at some point in the future, it will look more like a value-based care arrangement, and even in some instances, more accountable types of care. than it does today.
Well, I'm glad you had an expansive answer. That was really very informative to me, and I hope to listeners as well, that there is real benefit to building services that you want to proliferate into the fee-for-service system, because it ripples out, and as you note, it changes clinician expectations, behavior. It creates a funding pathway. It goes into the base of the ACO model. So that was really helpful to me. I have some great questions from the audience, and I want to pull them in some of the themes that they've brought up. One is a very familiar question to me, which is, always about halfway through a conversation like this, you realize that we've been talking clinician, provider, clinician, payer, and patient, although we did have a brief discussion of patient-reported outcomes. The actual enrollees, tend to come late in the conversation, because we're talking about billing codes, we're talking about payment models. And one of the questions of, and this goes back to some of the attribution questions that I don't think we need to get into here. But, when you sign up for Medicare Advantage, you're signing up for a plan, you go through maybe a broker, you're very clear, you get a different card with a different, health plan. A lot of these models are invisible to the patient and the enrollee. And so if we're doing this, presumably we're doing all of this for them ultimately, or else we're just spinning our wheels here. Where is the patient in all of this? In choice, in defining quality, in even knowing that they're part of what may be an experiment to figure out what the future of Medicare should look like?
Really thinking about the patient, I'm so glad you asked, because that's really our North Star here in terms of the types of changes we're trying to make. It's why we're trying to get to more accountable care, is because we think it'll be better for patients. And research has shown that ACO type models, they save money, they can improve patient experience. We've seen that when we look at ACOs in the shared savings program compared to similar other types of physician groups that aren't ACOs, we see improved quality. So I think there's a lot of reasons for a patient that they should theoretically want to be seeing a clinician as part of an ACO. Historically, it has been very challenging, I think, for patients to grasp what it means to be going to a provider who's part of an ACO. And I don't blame folks at all for that. I mean, it's really, the healthcare system's incredibly complicated. And so one of the ways that we're trying to address this is through essentially beneficiary notification, and we've changed the way that this has been done over time. We saw historically that when beneficiaries were notified that they were part of, they're seeing a clinician, part of an ACO, they thought it was actually an MA plan, and they got confused. And so we did a lot of focus groups trying to make that language a lot more patient-friendly and easier to understand. So we made those changes. I will say, though, it speaks to something larger about this larger question of how do we make sure that patients are more feeling the benefit that they are receiving. And so communicating about ACOs in ways such that, which is true, that ACOs are sharing data and to help keep you safe. And they're identifying when you as a patient are going and have an inpatient admission and trying to make sure that when you come back, that your medication list is right, that you're able to do all that follow-up care that the hospital said that you should get. And a lot of that is the transition between different care environments. And the other piece is ACOs also have a lot more flexibility to meet patient needs outside of traditional Medicare or a fee-for-service payment arrangement. What I mean by that is at the end of the year, when they get those shared savings, they can use those dollars to do things that can't otherwise do in Medicare. Pay for meal delivery, housing supports, transportation, better do care management and care coordination, and all of those good things. And so we also created, in that same vein, advanced investment payments such that ACOs can get some of these payments up front rather than waiting until the end of the year, getting upfront payments for these new smaller ACOs, and that they can use these payments to more directly address beneficiary needs, whether that's unmet social needs or otherwise. And so we've been also thinking about how we can improve this kind of flexibility that ACOs have to better address unmet social needs. I know this gets a little bit into the equity category, but And we also think that as a side effect of that, could allow beneficiaries to more feel that impact of what it means to be part of an ACO. Just like when they're in an MA plan, they might feel the impact of having a supplemental benefit or not, but trying to think more about that from a patient experience perspective.
Well, I'll be eager to see how that evolves. It's a topic we've been discussing for so long, and it's hard to figure out how to provide a benefit. Sometimes, and again, in MA, they're very visible because you have supplemental benefits and the like. And so if you ever got to a place where there was something as visible as that would be notable. But in the structure we have right now, that's not really happening. And so that'll be interesting to see how that evolves. I want to bring another topic. I've gotten a lot of great questions for those in the audience. If I don't ask yours, please understand I'm fielding many of them. But a question about alignment between Medicare and Medicaid, and particularly given your state experience, and I've had it as well. I'm always interested in that. You, of course, sit as the CTO in the Center for Medicare, and Medicare is plenty big to align just within it. But can you talk a little bit about sort of how you work with your Medicaid colleagues and whether there are alignment visions across here? You did mention some quality measures that sound like they'd be potentially more applicable even to the Medicaid population, the Medicare population, but any dimension like that, we'd like to hear some more from you.
Yeah, absolutely. It's a great topic. And I think it's super important, given my experience in both Medicaid and Medicare, to think about how alignment happens across these settings. And so one is the quality measures that I discussed earlier. Those universal foundation quality measures either have been or are being currently contemplated for Medicaid core sets, and also some of the Medicaid managed care provisions. They think about that on their end in the Center for Medicaid and CHIP Services, CMCS. And when we created the Universal Foundation, in part, the measures we chose were because of their applicability in a Medicaid context, in a Medicare context, in a commercial market. And so we think that element of alignment is certainly important. The other area that I wanted to highlight in particular, though, we talked a little bit about codes today. So when Medicare comes out with a code, state Medicaid agencies can decide to pay for that code. And so when a provider is providing a service, it becomes hard if you have to bill one thing for Medicare and you have to bill something else, or you can't bill it at all in like a different payer context. And so oftentimes state Medicaid agencies and also commercial payers will take the codes that Medicare develops and use them. And I think particularly when we're talking about some of these services related to community health workers, they're especially applicable in a Medicaid context. And so we definitely talk with our Medicaid colleagues and better understand, like, hey, is this code something that would be applicable in your setting? And the other area that I wanted to point out, and another area that I've been heavily focused on over time, is in the behavioral health context. So we have, and then that applies to some of the code related issues and considerations, but it also applies to our valuation. And so oftentimes what Medicare does in terms of valuation can be replicated either at a state level, state Medicaid programs, also by commercial insurers because of their contracts with providers. And so something that we've done over time, and we've really been trying to promote the uptake of behavioral health services and access to behavioral health services across both Medicaid and Medicare and in the commercial market. And so in Medicare, we've said with this finalized physician fee schedule, we're increasing the payment for timed behavioral health services like psychotherapy and a lot of the different behavioral health integration type codes. And so integrating behavioral health into primary care context. And so these changes do have ripple effects that also create alignment as well at both the state Medicaid level and commercial payers too.
You started to touch on the third dimension of equity, and I want to bring it in sort of full force here. I'm going to start with my pet peeve here. Forgive me, but since I'm having such a fun time talking to you. I want to hear how you respond to it. Which is this notion of, creating sort of incentives to address social needs, which I'm all in favor of. But then, the underlying notion that they're going to save health costs, that's sort of the formula here is that if we address these social needs, they'll reduce health costs. And that's a very constraining approach to addressing social needs, and potentially very distorting. There are lots of social needs that need to be met, whether they affect health costs or not, and you end up with sort of doing sort of some math calculations as opposed to patient-centered, population-centered. What do people need? It's more like, well, where can we make a buck if we spend 50 cents? So before we get into some of the specific initiatives, I just wonder if you could talk a little bit about sort of the general conceptual framework of what is the foundation for addressing social needs, and the way of thinking about what the goals are in doing so.
Yeah, it's a really important question. I'll start just for our rationale and reasoning. So I came most recently before this job. I was in Pennsylvania, and in Pennsylvania, like other states around the country, there are profound inequities by where you're born. So if you're born, for example, in one census tract in northern Philadelphia, your life expectancy might be 62, 63 years old. If you're born just a mile to the south, your life expectancy goes up to 83, 84, differences of about 21 life years. If you're born in one census tract in Erie, Pennsylvania, your life expectancy is 61, goes up to 82 in the census tract right next to it. And so there are these profound inequities by where we live, and a lot of that is based in this social determinants of health, so unmet social needs. These are the same areas that have been historically redlined, that have worse access to food, worse access to stable housing, worse access to healthcare, have more pollution, and so one policy change is not going to change all of that overnight. But I think that CMS is thinking about our different levers to better address social needs. I think in Medicare, we have the ability, in a traditional Medicare context, to pay for the work that providers are doing. And providers are increasingly doing work in this space, like trying to make sure that patients are being navigated appropriately, working with teams that include community health workers and behavioral health providers, and trying to make sure that the patients are getting the services that they need. And so number one, I think, is just making sure that we pay for that work appropriately. Two, this area though of like the social needs themselves, so whether that's food or like actual housing supports, or we have more limited ways that we can address that in Medicare by statute. And a lot of that has to do with it's either in the supplemental benefits on the Medicare Advantage side, or it is in what ACOs are doing in terms of their shared savings, like we talked about earlier. And I think in those contexts, it's either the Medicare Advantage organization or it's the ACO that are making those ROI calculations. And so that being said, there are areas that make financial sense and just intuitive sense to like address social needs. And so I think increasingly, and I say that this is on the Medicare side. Medicaid has more flexibilities, and we have now, we're getting some additional information related to evaluation reports and the kind of health communities model, and that shows some initial promise too. So I think that is all to say that while it's important to do all of the aspects to address these unmet social needs, whether that's provider work, whether that's using what flexibilities we do have to address the underlying needs themselves. And it's also working, and with this approach, it's also working with community-based organizations, because community-based organizations have been addressing these unmet social needs for decades. And I think that oftentimes is a lot newer in healthcare context. And so the impetus is to automatically try to do everything yourself. That's oftentimes in a medical context. But what we're really trying to foster is these partnerships with pre-existing community-based organizations. And so with a lot of the changes that we're making, trying to build on that infrastructure that currently exists, we think can go a much longer way using those trusted community sources as well.
Okay, so that's great, and brings me to sort of the next topic that always comes up here, and a question came in on this topic as well. So bringing in community-based organizations, people on the ground who know what's going on, makes a lot of sense. But the question is, what are you bringing them in for, right? Are we bringing them in, and we've published papers about this in Health Affairs, are we bringing them in essence as contractors to solve, one person at a time issues? You don't have stable housing, we're going to help you find housing. You don't have access to the food you need, we're going to help you. Or if you talk to most of the people in those organizations, they will talk about population-based strategies. They'll talk about, as you mentioned, sort of access to food and affordable housing and living wages. And I understand it's not Medicare's job to go out and advocate for living wages, but I do wonder, when you describe engaging with these kinds of organizations, is it still at the sort of partner to treat my patient level, or is it more of a population health approach, or both? And if it's any of the latter, I'd actually be really particularly interested in that, because I know it's the former. I know we're working on getting services to individual patients.
Yeah, it's a great question. So a lot of the community-based organizations that we're talking about, they get their traditional funding through grants, and a lot of the grants are trying to address these population level issues. Increasingly on the ACO side, for example, as we're pushing accountable care organization formation, ACOs are also really looking at a population-based level, but they're looking at different things. They're looking at potentially health outcomes, care measures that they're being measured upon. And so I think increasingly, where I would also like to see this go is getting from more of an individual patient perspective, like screening, sending to the CBO, but also these more established, once these partnerships become more established, and as healthcare providers are also increasingly thinking at a population-based level, really pulling CBOs in as thought partners here, and addressing those unmet needs from a population perspective. And so we also, a while back, it was also in Health Affairs forefront. There was an HHS piece that came out about the idea of community care hubs, and the fact that there's all these community-based organizations that exist, and oftentimes they lack the ability to do things like exchange data, or understand, or to close the loop with some of the data systems. And these larger organizations, community care hubs, that act as these bridge organizations between CBOs and providers, I think are well primed to also they have also been thinking at a population-based level and act as partners to ACOs and other providers, as the connection point between CBOs there as well. So basically, I agree. I think we are in this one area of like a by-patient approach, but increasingly, as we look at additional flexibilities and ways to have ACOs and MA plans partner, I think getting to more of this population-based approach is super important.
I hope you're right about the growing attention to population. That would be a really critical development. I want to cover a few more things, but I do want to quickly ask one more question that came in the audience about rural. And at least the last time I looked at the data, I don't keep it all in my head, but I think MA is more dominant in rural areas. And certainly the building of ACOs is challenging sometimes in more rural areas. So I just wonder again, sort of what sort of infrastructure you feel exists to address the inequities that are rural urban.
Yeah, it's a great question. So one of the things we've specifically done in the Medicare Shared Savings Program is we have created these advanced investment payments. And we said that these advanced investment payments will give you $250,000 up front, and then we'll pay quarterly payments based on the type of population that you're serving. And so if you're serving dually eligible, like people receiving low income subsidies for Medicare Part D, also that are living in areas with high area deprivation indexes, which include really rural areas across the country, that those payments will be higher on a quarterly basis. And so we're actively trying to recruit ACOs in this area, participate in the Medicare Shared Savings Program. And we've seen that ACOs that are participating in this first round in 2024, there's 19 new ACOs. They're serving disproportionately underserved populations as well. We are also thinking about, there's a few other areas that I wanted to highlight. We also created a new provider designation of rural emergency hospitals. And these are new types of providers that can enroll in Medicare, or rural hospitals that otherwise might be closing can sign up as a rural emergency hospital. And we've seen some of those signups over time. And then the other area on the Medicare Advantage side, so Medicare Advantage, it's growing in rural areas. And one of the areas that we've particularly been focused on recently is looking at network adequacy as a way to promote that contracting in rural areas. And so that includes, for example, like new, specifically in the behavioral health space where that's been such an access issue, we've included new network adequacy categories for licensed clinical social workers, for clinical psychologists, and actually we just proposed a new a new a network adequacy category for marriage and family therapists and mental health counselors. And so, and those are actually, there's a new Medicare benefit in general for marriage and family therapists and mental health counselors. We're also now paying for intensive outpatient services. So through the network adequacy lever, though, on the Medicare Advantage side, what that does is it increases the leverage that providers have that operate in those areas to get the rates that they need. And because otherwise we want to approve the Medicare Advantage bid. So we're thinking about rural in like lots of different contexts in the value-based care space and outside of it.
That's great. I want to turn a little bit to your path here, not just as I always end with a question about career, but we're not quite at the end here. I'm struck because I spent years in the Medicaid world, and sort of that's what I'd say I know best. And you come out of state, work with Medicaid, and here you are on the Medicare side. I never made that move over. So before I get into sort of the personal career elements of it, I'd love to hear sort of from a policy development, policy execution perspective. These are, the two largest healthcare programs in the country. The structure of how we run them and set policy for them and administer them. I mean, there's almost no dimension you can't think of where they're where you can't find big differences. You've had now the opportunity to sit in both, and most people don't get that opportunity. So I'd just love to hear some observations about what you think either one could learn from the other, or what lessons maybe from the Medicaid world you've brought over that you feel give you a better opportunity working in Medicare. Just some insight because of the importance of these two programs and their differences.
Oh, that's a great question. There's so many things to, so many different directions we could go.
That's why I did it, but that's why I did it with more than 2 minutes left in the program.
I think that there's a lot of really important lessons learned in a Medicaid context. I think some of them, I think it's an old adage, but it's absolutely true in the Medicaid context. If you've seen one state, you've seen one state, and every state is totally different in their state Medicaid program. And so I had one singular experience in Pennsylvania. I mean, you had an experience in Colorado, and I think that like in Pennsylvania, for example, there's a managed care on the physical health of Medicaid. There's a managed care behavioral health. There's a managed care long-term services and supports. There's a managed CHIP plan, and trying to coordinate all of those managed care plans, which are oftentimes the same parent organization, and like creating cohesive policy and thinking through that collectively was both an opportunity and a challenge. And I think at a state level, you're oftentimes very close to individual providers, like all of the different like FQHCs and the different health systems and the people at those health systems. And so and also so do all the state legislatures as well, and they will come and talk to you about that. And so that's also a tremendous opportunity to have conversations with folks and to really understand in intricate detail like what's going on and what could be improved. And I think there's also a lot of important state flexibilities that exist in Medicaid that we don't necessarily have in the Medicare statute space. And but that being said, I think on the Medicare space, there's we do so much now that's via regulation, and everything comes out via regulation. And so learning when the regulations have are going to come out, what the opportunities are for each regulation. I mean, it's very exciting when a change happens in Medicare that it exists nationally. And it has such a tremendous power, I think, to change healthcare in this country when Medicare comes out with a change as well. And also, I think folks at Medicare have potentially a lot to learn on from folks on the Medicaid side. It's like, what's most important, particularly as we talk about equity, what's most important in terms of how we pay for services that will really impact people who are the most underserved across our country. And that's been something that I've really been, I felt like because of my state Medicaid experience, I've been able to bring into a Medicare context that not everybody gets to. And that's been really rewarding for me in thinking about how do we use the machinery of Medicare to promote health equity.
That's really helpful. Thank you. I want to follow up on something that it's again should have been obvious to me, but it was one of those moments when you mentioned the proliferation of different types of Medicaid managed care, partly carving out parts of people, which is always a bit troubling. But the fact is, we have decades of experience with Medicaid managed care, and it's it's entrenched. It's certainly not going to suggest it's without its challenges, but it's certainly a fully accepted dimension and dominant dimension of the Medicaid and CHIP programs for the vast majority of the population. We have this battle going on in Medicare about, we're at the 50-50 mark between MA and traditional. There are all kinds of challenges about payment and marketing and supplemental benefits that are available in one and not the other. Is there anything from navigating the proliferation of managed care, but also the established nature of managed care and Medicaid, that helps you think about how to navigate these very controversial waters when it comes to Medicare?
Yeah, I think there's a lot of lessons learned, and oftentimes it's really the same company that's doing Medicaid managed care and Medicare Advantage. And I think there are important lessons to learn. There are important differences as well, as I've also come to appreciate. But I think that, for example, I think something that the state of Pennsylvania does really well is they look at all of the prior authorization requirements of all of the Medicaid managed care organizations and are really intentional about thinking through all of them and making sure that it's based on evidence and that it supports patient care in a meaningful way. And one of the changes that we've made in Medicare Advantage in the last couple of years, we finalized regulations that said that Medicare Advantage cannot have prior authorization that's more restrictive than traditional Medicare. And we're requiring Medicare Advantage plans to put out all of their evidence related to each individual prior authorization criteria. We're also we're proposed that that managed care organizations and Medicare Advantage have to also like do health equity analyses and making sure that the information related to how are these prior authorization policies affecting people who are underserved, that information is transparent over time. So that's in the proposed state. So I think that there's a lot of there's a lot of similarities when it comes to managed care. There's also like network adequacy requirements exist in Medicaid managed care organizations, similar access challenges and opportunities. And also we talked about the quality measures too. That's another area of overlap. So there's a lot of, I think, areas where programs can learn from one another. There's different statutory bases for some of the areas, so that becomes somewhat of a more challenging aspect, but I think there's a lot of opportunities to learn from one another as well.
But it's a good reminder that it has taken decades for states to build the infrastructure to figure out how to view managed care as to figure out how to work with the levers they have with respect to managed care companies. Because on the one hand, you're buying a product, you're saying you guys go do it. Oh, but we're going to hold you accountable. Well, what does that look like? How do we actually do that? What information do we need? What tools do we have? What corrective approaches do we take? How do we keep it a positive relationship with appropriate information flows and the ability to sanction when things go wrong? Like that's a skill set that that has taken decades for states to learn. And so maybe part of it is just a certain amount of humility about as MA has grown and as the legal framework in which managed care operates in Medicare has evolved, because it hasn't just been one program, that we should expect a learning curve within the agency on how to do this as well as possible. It sounds like the network adequacy is an example.
Absolutely. Yeah.
Well, one of our rules at Health Fairs is we always end on time. So I'm going to ask you if you have a minute of something that I didn't touch on that I know your portfolio is more than this. We did stick pretty close to some of the core topics, but if there's something you wish that I had asked you about, I'll give you a minute to say that, and then I'll wrap us up with the audience.
I think we touched on a lot today. I wanted to just come back to one thing I highlighted in like as part of a half answer. The new model that just came out today, the primary care flex model, new model in the Medicare Shared Savings Program. Check out the CMS website. There's some information on it. We're really excited about this new model, enhancing primary care payments and promoting accountable care all in one, and changing the way that primary care is paid in the Medicare Shared Savings Program. So the Innovation Center is planning to also host an additional webinar for folks who want to learn more about it. Yeah, if you're listening and that's of interest to you, stay tuned for more information.
Great, thank you. Yes, it's always, and that's, that also highlights something you said a moment ago, which is that because of the dominant role of regulation, things can change in big chunks with the drop of a few pens, and so paying attention to those and then having a follow-up for people to inquire and learn more is a really important part of what you do. Well, Doug, thank you so much for the conversation. It's been really interesting to hear from you, to learn about your work, and I just appreciate you making the time. I know there's a lot to say, and a lot you need to be doing other than talking to me.